Yeah, good morning, ladies and gentlemen. I'm going to discuss with you the transposition of the great arteries. I had to change something in my talk because last week I've seen a patient for a second opinion with the transposition and I asked her to come today for the live demo. I said, okay, why not? I said, we will learn a lot of you and so. And I decided to focus during the live demo on some science, but she called yesterday and she said she didn't find a babysitter for her other child and she can't come. I told her, bring your child with you, but she's coming from 200 kilometers away, then it's not that next door place. So I will discuss with you several issues. It's difficult to teach people how to do the transposition, but I will show you some aspects. First of all, this is one of the most important papers published at that time. It is more than 14 years ago. I remember it was rejected first in one of the papers because I know the group who published this. And this was one of the first papers showing that it makes sense to perform a prenatal diagnosis. Otherwise, until that time, no one was saying that it makes sense to make a prenatal diagnosis because you need to confirm what's happening. And the group in Paris and around Paris compared prenatal diagnosed transposition. Imagine in the late 90s to have 68 cases, it was something very, very rare worldwide. And they showed that the age admission, the metabolic acidosis, mortality, and preoperative and postoperative and hospital stay are significantly different. And it makes, it has a big benefit to make this diagnosis antenatally. Now, when you prepare such a talk, you check what is in the literature. And there is one paper of the series in Heart where they take a condition like transposition and they write from the fetus to adult and assume to find a lot of information there. But in the 9 pages, there were 12 lines on the transposition stating here that disappointingly the rate is still around 20% in many centers in the world. So this is probably not true. And how good is actually the detection rate antenatally? It can be less than 20%. If you look at the study, the classical study of Bull in the Lancet 99, they examined the southeast region in the UK and found that for univentricular heart and hypoplastic left heart, let's say the univentricular heart detection rate, more than half of the cases, but for conditions like transposition, it was 3%. It is obvious because at that time, it was the policy in the UK to teach the 4-chamber view in many centers, and all people you know from the UK, Giulini, Helena, Gardiner, Lindsay Allen, Gerline Charland, and we're going to units and teaching people to do the 4-chamber view. In the meantime, we are changing, and I hope with the guidelines, things become improved. But it was not, let's say, the aim at that time to detect transposition, but if you teach people to do, let's say, a complete cardiac scan and not to focus on one plane, you may improve. And if you look at the study done by Bartlett and co-workers, they said, well, there is a better improvement just postnatally, but actually there is not so really big difference at 1 year of age, especially in many regions where you have good access to medicine, and they compared the 25 prenatal cases versus 321 postnatally. So these data were published by Cochenoud, the epidemiologist in France, and I put together the hypoplastic left heart syndrome and how the development of scanning. And the French group is worldwide actually still the best people doing the job because Laurent Fermot started to do this in the late 70s, and he achieved to have a very good screening program. And for hypoplastic left heart, at the beginning, it was 30%, increasing to 82%, and then to 90%. And for the transposition, it was, of course, less. But then they rapidly improved. And Laurent told me last time I met him that, and you remember, for the one who were last year in Paris, they had detection rate in the Paris region around 90%. And actually, this is what should be on one hand. But many of you who are specialists said, how can they detect only 3 out of 4 cases, because we can do it. But you are the teacher for the other one. And every one of us wish to have all patients to scan because we can deliver good policy. But this is difficult to get these high-risk patients because transposition has practically no high risk. Now in Germany, we have done a large pediatric cardiology study examining 7,000 cardiac problems, and 156 had transposition which is the prevalence, which is 2.3 out of 10,000 births. But here in Germany, the detection rate was, it was not the focus of the paper, but roughly 15%. And to be politically correct, to my understanding, they decided not to compare the different lenders because otherwise it can have impact on insurance companies, because we have in Berlin a very high detection rate. For two reasons. First of all, people here are very good by definition. No, but they are very good because we have a very good level of ultrasound. But you cannot, it's not enough to have good level of ultrasound if you don't get the patients. And we are very, very lucky that our normal treating gynecologists refer by definition almost all patients to one of these specialists. And all of these specialists are sitting in this room. It's Berlin plus suburb, which is 200 kilometers north and south. That means it's the previous Eastern Germany until the border. And we have Berlin being center, and Felixberger is cooperating with all of them, but we have another center in Leipzig. And we have good data because patients are referred, and we are doing good job. And you see here, this is our data from last year. We had 43 fetuses with transposition, and one was not detected antenatally in our unit. It occurred. I will never say that everyone can have 100% detection rate, but you see that it is the exception to have one case not detected and not the rule, as is in many other places in this country and many countries. But we have actually 2 patients with the transposition on follow-up, and they will come at time to Felixberger for further therapy and treatment. Now, I have to confess that it's difficult to make it prenatally detectable. First of all, the patient history is not informative. Second, you rarely, almost always have never extracardiac abnormalities. They are nearly absent. And we are speaking on a complete transposition of the great arteries. That means not the one where you see parallel vessels. This is a separate entity. The 4-chamber view appears normal. The 5-chamber view appears nearly normal. I'll show you later on. And then the color Doppler is not really helpful if you don't know what you are suspecting. That means the detection is really done by an experienced examiner, because there is no single plane where you see it straightforward. You need to have a kind of suspicion and then rotate the transducer in order to get the crossing. And the crossing can only be seen by moving the transducer up and down. Now, how to teach to detect prenatally transposition? There is only one way. Organize courses and go to courses. And you see we are always organizing courses here locally and German-wide. And as you see, this time we are doing it also more international with 55 countries. But let's say a rule of thumb. This is what I said yesterday for the corpus callosum. The more you have some hints and some signs, the more difficult is the condition. That means if you have a transposition and the transposition looks like a transposition, it means it's easy to detect. But if you have one telling you, you look for the parallel course. The other one tells you, no, you have to check for, there is no circle and sausage sign. The third one describes the sad aorta sign because the aorta is bent. The other one says it's the aortic right convexity, the big eyed frog sign on 3D, and spin technique and star technique and the I sign instead of the V sign. That means the more signs you have, the more difficult we are making things to be understood. Now, how can we improve? We have to teach, first of all, normality, and especially you need to perform a large number of scans. And this is what Gustavo was saying yesterday. You have to learn that the more you are doing, the more you see what is normal, and then you see that something looks abnormal, and especially, as you see on this clip, that the spatial arrangement of the vessel is not shown. We look at the aorta ascending here and the crossing of the pulmonary artery. And this is only a kind of sweep, but there are also additional signs. What is the detransposition? I'll make it short because these are things you are supposed to know if you visit such an advanced course. It is 5% of all cardiac defects. We nearly have no extracardiac anomalies and no chromosomal aberrations. At the level of the heart, we may have, it seems, 20% VSD or pulmonary stenosis, but we don't have that high in the fetal studies. Now, once you see, however, a parallel course of the great vessels, it is not automatical transposition of the great arteries. And there are enough papers showing that in a group of detected parallel vessels, it is something else. In general, I will recommend you the first time you see a fetus having something plus parallel vessels, it's almost always double outlet right ventricle. This is very, very common, and these are the fetuses having trisomy 18, they have an omphalocele, they have severe malformations, they have brain problems, and then you see the parallel vessels and this double outlet right ventricle. It could be also a complex cardiac problem with malposed vessels. This is why we describe, when we describe a finding, not transposition, we describe malposition in a complex cardiac condition, because if you use the word transposition in counseling, which is not always done online during the live scan, but afterwards with a finding, patient may be counseled very positively as an easy procedure to be corrected, where in double outlet right ventricle it can be very complicated. So these two images may show you a simple, not hint, but an aspect that the parallel course of the vessel seems to be easy to see if you have the time to rotate the transducer until you see it. But what you see here are the arrows. The arrows show to the rib. And the ribs means you are not in a true axial plane. You are already here in an oblique plane. That means there is no single classical plane where you see the parallel vessels. The parallel vessels, you see them once you know that it is a transposition, or you suspect it is a transposition. And you see here how the video will do this. We'll see something, and then I start rotating the transducer until getting a kind of longitudinal or parasagittal view, and then you see here the different ribs. And sometimes you even see the stomach. The four-chamber view is nearly non-informative. There was an observation that the foramen ovale is bulging sometimes to the right side. It's true, but believe me, if you are so good to observe the foramen ovale bulging, take the time and look at the great vessel. It's more easy, actually. So, and look at this one. Again, you see here the sternum and the upper. This is why I get rather longitudinal view. And look at this, the difference between the normal course, the parallel course of the vessels, and you see here the stomach and the diaphragm. I want to let you understand by different images that the plane is rather plane from the right shoulder to the left hip, instead of a plane where you check from the five-chamber view and you get it in that plane. So, and you see here again the oblique view with the diaphragm and with the stomach. Now, are there ways to detect easily transposition? First of all, the four-chamber view, as I told you, is not informative. You then tilt the transducer to get the five-chamber view. And this is the moment where many of our colleagues stop to work. They say, okay, I see the four and the five-chamber view, and it's enough. But this is why we're pushed for the guidelines, because then you are obliged in a way to implement more and more the three-vessel trachea view. At the beginning, it can be difficult, but you will see that it's easy. Why it appears normal? Because there is anyway a vessel arising from here. This vessel is not overriding like in tetralogy of Fallot or double outlet right ventricle. That means a vessel is there, and since you have seen this vessel, you think four and five chambers are normal, and you move and you jump and you say, okay, the other one are patent, and then you just miss this condition. And observe this video clip, because this is one of the most important clips I'm going to show you today. Why is this five-chamber view abnormal? First, let's say easily, because you recognize that this bifurcation is there. If you are bad, you think this is the aortic arc and this is the brachiocephalic. But what is typical is it's this unusual large vessel. And this is why I've done once diagnosis on the telephone. A colleague, experienced one, called me and said, I'm suspecting an aortic stenosis. I think it's a severe one. Why? Because the ascending aorta and the five-chamber view is dilated. How are the velocities? It's at 80. So can you repeat 80 and you have it dilated? No, this is probably the pulmonary trunk. Send me the patient, said exactly what I assumed. Suspicion was aortic stenosis because she assumed that this is post-stenotic dilatation, but this is the normal large root of a pulmonary artery. And this valve is normal. And this is what you see. If you have the impression the aortic root is dilated, think about it, could be also the pulmonary artery. And then you continue and you see the bifurcation. Sometimes this route appears so abnormal for the examiner because in general we have a smooth going up to the right, and this bulging to the right is also some suspicious, leading to some VST or overriding suspicions. So, and then we move to the three-vessel view, and you see then only the aorta and the superior vena cava. If you turn the transducer and you see it from here, it's the sad aortic sign, but this for me a happy aortic sign because smiling. So some, especially in France, they are teaching the people to check for the short axis view because the cardiologists are the one doing the teaching. And this is why I think it's too complicated. It has the disadvantage that some are discouraged, but it's had the advantage that it makes fetal heart so complicated that people still have respect. Oh, it's something so difficult. I need someone to help me. But actually, this is a plane you will only understand if you really are scanning, let's say, in infant hearts. But they seem to have succeeded with this plane, that the aorta is more anterior, posterior is the pulmonary artery with the bifurcation of both pulmonary arteries. That means you don't have this circular sausage sign. I think the most interesting sign we should teach is what we were saying for several years, which is the three-vessel trachea view. Here, as you see this plane, and Giulini pointed to this, and we have just finished a paper on an overview. It is going to be published late in this year in one issue, which is dedicated to the fetal and neonatal heart. There will be a chapter on the hybrid procedure and chapter on MR of the fetal heart and so on. And Helena Gardner and me wrote an article on the three-vessel trachea view with new schemes. And there we discuss the different abnormalities you can detect in this simple plane. And I hope that people who are going to read the guidelines, they can use this paper to have a hint. What do we see in this plane? We see, as you have heard before, and we'll show it in this afternoon, pulmonary trunk, ductus arteriosus, aorta, because these vessels, once they have crossed over each other, they come to merge at this level, isthmus and ductus, and you see the V sign. But in a transposition, you see only one vessel. So why? Because we have a kind of anterior position of the aorta and superior. And as I told you, because we see it in the more longitudinal plane, the pulmonary artery is hidden under the aorta. The first time I was realizing that this is the case, I said, why is this fetus, and this is probably what you may have next week or the week after, why is this fetus having, on one hand, a normal four-chamber view? Well, this one had a small VST, but it's the exception. A normal four-chamber view, but it doesn't fit to one outlet. And I was going up and down, and I saw only one vessel. Why did this happen? Because there was the other vessel was just under this one, but I didn't realize there are two separate vessels. I was cutting once the aorta and the other one, the pulmonary artery, and coming back to the aorta. And then what you do, you should do only one thing. This is the moment you should turn your transducer, and you see if you have a vessel under this one. Now, of course, it's easy to say this if you are 26 weeks, but the same you can do it at 12 weeks and always. And the same can also be done by reducing some color and observing, do we have a vessel here or there? Because in hypoplastic left heart syndrome, we have here a problem, but by reducing the color, we see the reverse flow in the aorta. This is, in the aorta, and this would be the pulmonary trunk. In other words, the main message today is go for the typical plane, check for the fourth-chamber view, think about a possible dilation of the vessel arising in the fourth, five-chamber view, and then move to the great vessels. If you see one large vessel making kind of abnormal bending, then rotate and get a nearly longitudinal view. And this is here what you see and what you suspect. Of course, once you have seen this, you may go for this, but this is not so obvious, especially from the lateral view. And then you see this this vessel. Now, this is just, I had the chance to review both of these. I guess, Giulini, you were one of the other one who reviewed these paper for the White Journal, and they are going out. It's not, still online, but not yet published. This is a group from Australia, Menachem, and a friend here, my friend Simon Mayer, and you see the convexity, they call it the rightward convexity of the great vessel. And a group from Japan, Ishii and co-workers, they called it the I sign. I suggested to have the title I-shaped instead of V-shaped, that people, because I sign, what does it mean? Because if you don't know what it is, you may read it as L or, and this is why it should be understood that it's straight vessel. But it is not pathognomonic or typical for transposition. Nearly all malposed vessels will offer this picture. You will have it double outlet ventricle, you will have it in other conditions. This is why it is a hint, but not a final diagnosis. And this is here on a video clip how you can see it. You see here the 5-chamber view, and then you see this vessel in the 3-vessel trachea view. You rotate, but you are not able to get this V sign and in color the same. So, and using 3D, you can see what image we can produce. We are moving now the line, this OmniView line, to show you what is the plane showing in the level, at the level of the great vessels, the parallel course, because you know what you are looking for. And here, 2 cases from early gestation, upper thorax with the time is 13 weeks, and you see here 1 vessel, and then rotating, and you see here with the HD flow, the parallel course of the vessels. Detected, believe me, detected in this plane first, or suspected in this plane, and detect this. But especially that you see only one, and you assume first it could be a coarctation, where is the other one, and then you observe that there is a normal vessel, and then you rotate to get near longitudinal view. And at the beginning, I was so hopeful that by the indirect signs, you know, here the thickened nuchal or something else, or ductus venosus, or nothing abnormal. This is another fetus, 12 weeks, normal nuchal, normal ductus, normal 4-chamber view. And what you see here is the moving, and you see a kind of bending of this vessel, one vessel, where's the other one, rotating the transducer, and then getting here the parallel course of the vessel. It's not the best video clip I put for you this morning, but you see here that you can recognize that the parallel vessels are there, completing this picture. I hope this is a good new for you, that you can use it, and you see here that if you are lucky, you can get a longitudinal view, and you can show it on 3D, but 3D can be used for other and better purposes, as I'm going to show you. My dream is to have such an equipment. Well, I have such an equipment, but that everyone can afford to have such an equipment that is so easy that once you look to the 4-chamber view, you hit a button, and automatically you have the complete heart scene where you see the parallel course of the vessels instead of the crossing. But in almost all machines, these software are present in the high-end machine and not in the machine used for screening and the cheapest machine. It should be the other way around. Now, once we detect this condition, we'll discuss with the cardiologist, but in general, before, we need to know, first of all, we offer patients a second opinion, or they got offered second opinion when they come to us. We have to counsel them on outcome, and you will hear later on what to tell the parents. But before saying it's only this condition, we may need occasionally some additional findings and to prepare the neonatal period. So what are the questions to be addressed in general once we detect a transposition? Are there extra cardiac malformations? Because you may be sure it's a simple transposition, but occasionally it's not. It could be VSC and then turn out to be double outlet right ventricle. And are there other cardiac problems? Do we know the patterns of CHT? And this here, you can apply to all cardiac anomalies by definition, that we need more information. First of all, for transposition, we need the association, whether it's associated or not with the VST and with the pulmonary stenosis. Don't forget, and you will see it later on, that stenosis of this valve is going to be later on the aortic valve, which is the main valve of the body. And this is why it's also important to know, and this is a common condition. The VST may show that the child may not have big problems after birth in concern of cyanosis, hypoxemia on one hand, but may need additional operation to close the VST. So this here is a nice scheme I did for you to understand that once you have a transposition with a VST, especially if it's a little bit large VST, doubt in writing the transposition of the great arteries, because it's very likely and very often going to run into double outlet right ventricle. And see the difference here. I have put 2 schemas over each other, left ventricle, right ventricle transposition, and I open a gap here, and by hitting the button, you see that this shift to here and the diagnosis changed. It's very, very similar. And believe me, it's not that easy to detect that this is aligned or not aligned. And sometimes you think at the beginning, this is why in every finding we write with the more or less, not a minor VST, but a larger VST, we write double outlet right ventricle with VST, or it could be detransposition with VST. We have to be fair, to tell the cardiologist that we are in this two group of disease, because they may decide to have another counseling for operation. And this looks to be a transposition because the vessels are parallel. But look at the four-chamber view. What you see here is an AV canal. You see a right aortic arc, and you see the vessels are in a transposition. This is why we call this malposition. In general, I told you there is no reason to have a suspicion of chromosomal abnormalities, but this is not a normal, complete, simple or complete transposition. This is a complex one, and this fetus had microdeletion 22, and you see here there is nearly no thymus in this plane. What I want to show you that one plane does not give you the whole story. You need the complete information, and this group is not the detransposition we are speaking about. This is a complex condition. Or the same here. This is a video clip I show in another talk on the so-called corrected transposition of the great arteries. Look at this one. It's difficult, but I'm sure you are so good that you will understand it. The right and the left side, and Dari will show us, I guess, similar examples later on. This is the left atrium with the foramen ovale here, as you see. And this is anatomically the right ventricle. Okay? That means we have already here atrioventricular discordance. We have anatomical right atrium with the anatomical left ventricle, atrioventricular discordance. Look at the video clip. From this ventricle, which is the right one, we see the normal aorta and the dilated pulmonary artery. That means we have, from the right ventricle, the aorta arising. It is a transposition, because this is the wrong vessel. It is a ventriculo-arterial discordance. What we have here is a typical picture of a congenitally corrected transposition of the great arteries. But how are the vessels arranged? This is on the right side of the pulmonary artery, and this is why it is a D-malposition. When I started to learn pediatric cardiology, I mean, in books, I never had the chance to learn it in the clinic, but I did well, actually. And I assume this condition should be called LTGA because it's an L transposition. And this is a classical example that the corrected transposition is something completely different than LTGA. This was called in the past, but it's not an L, it is a D transposition, but with the correct, congenitally corrected. Do you get the point? Because we have L means it's always on the left side, but because the heart is on the right, it changed everything, and we have here a D malposed vessels. This is why what he needs from us is a description on everything we see, because if you tell them they should know that the heart is on the right side, how do we need an operation or not? Do you think we need an operation just after birth for this condition? Arterialized blood will come to the left atrium and will go out of the aorta, and it's balanced. Okay. So next point, can we predict neonatal course? This is a tricky part, and this is the risk we are doing. You think you can relax once you have done the diagnosis? Not true, because in this paper written by Jean-Marie Joannick from the French group, they analyzed following. And this, you should know this because it can happen to you or to everyone. They analyzed the 130 fetuses in 5 years. They found that 119 had at least some abnormal shunt. I remember in the mid-90s, Laurent Fermont told me, please try to check in your patient the ductus, how the ductus venosus is putting blood through the foramen and the foramen. I didn't understand what he meant. He makes me a drawing. I returned back home, said, we have to try to do this. I will understand one of these days, and later on I know now how to do it. And he said you have to do it just before birth, before you decide it. So, and they had here 23 abnormal foramens, 5 ductus arteriosi, and then 4 both. 13 out of the 130 had profound hypoxemia. Atrial septostomy needing atrial septostomy within 30 minutes, and 2 having this condition died despite resuscitation. Died. You tell the parents, you are lucky, I detect this condition. Everyone does everything, and the child dies, even knowing the diagnosis 6 months before. This is why you should know that despite knowing the diagnosis, ductus arteriosus and foramen ovale can really kill the baby without the possibility of intervention because it's too late, everything you can do it. This is why in France, when they deliver always next door to the neonatology unit. I want to stress this point because many people tell me, in our place we deliver and then we transport by helicopter or by car. No, you should change your settings that you have the chance to give these children chance of survival, even if it's only 5% having such severe problem. And this is the only case I really saw, but until now what we are doing is when we see on antenatal ultrasound this diagnosis, we try to see the patient until 36 weeks before she goes to the clinic. This here is the 4-chamber view, diastole, systole, and you see the foramen and the septum is not even moving. You see a slight narrowing of the left chamber. This could be a hint. And then you see here the movements are not really occurring. And if you see it from the left side, you see here a really very narrow foramen ovale. And I told in this patient we need to have a postnatal intervention. And it was when I was working in the Charité Hospital. And she came with a premature rupture of membranes at 38 weeks. And I came from home on a Sunday to perform the cesarean section. And I followed with the baby, and just after birth, as you see, the foramen was closed, and after septostomy, it was open, and we had no problem. And you could observe how the oxygen saturation was decreasing just after birth. That means it makes sense to look at these conditions. And today, the challenge for us is not to make the diagnosis. You can do it, but to find the details and additional things. And what is still my big challenge now is what Dario published in the white paper. I think I put this paper on the CD as well. The coronary patterns, I started doing this in the late 90s to check if we can recognize the coronary arteries, but it's so difficult to confirm this on every fetus. This is why I abandoned this. But there were several papers saying that the course and the branching of the coronary artery are related also to the spatial orientation of the great vessels. In other words, if you see how the great vessels are arranged, you may tell the pediatric cardiologist, we may have a condition where coronary arteries may be abnormal. And we have done this in let's say 10 years ago, and published in a book that we can see on 3D the arrangement of the vessels. And this is what we presented in Stockholm, that you can see both valves, the aorta and the pulmonary trunk, anterior to it under normal conditions. And Dario got the great idea not to use this difficult technique, but to go straight forward. And you see here the aorta. And this is here in the condition of transposition. You don't see that this is the aorta, but you see that they are not over each other. The aorta is more demalposed. You see a transposition case. In normal conditions, you will have it here. It will be pulmonary and the aorta, and this is pulmonary and the aorta. That means this view can be of big help for the cardiologist. And he said, why use on 2D? Because the image is not so good. Use color Doppler and get this arrangement. In transposition, you may have anterior to the right aorta, you may have anterior, and you will have side by side. And this can be related to the abnormal coronary condition. And you see here, it can be done today, not with this sophisticated technique. You can take this line, which is the OmniView line, and you can do it. I'll show you an easier way to do it. This is an example of a normal condition. You have a volume, you take the line, you take the curved line, you put it from AV valve to AV valve, you bend a little bit into the ventricle, and you see on the right side the vessels, how they are arranged. Aorta and anterior is the pulmonary trunk. And an example of this is how you see it, the pathologic specimen. And you see the parallel course side by side in the case of a transposition. You don't see it here, but you see here the two vessels. it could be easy, but we need a little bit more experience on this field and people doing more and more 3D. So I come to my conclusions. I think I showed you that the transposition is possible. You knew it, I'm sure, but I showed you that the vessel arising from the left ventricle as a hint is rather dilated because of the pulmonary artery, that the three-vessel view should be one of the major planes you are going to learn now with this new guidelines. They show a straight great vessel, and then by rotating to get a nearly parasagittal view, you can get to your diagnosis. And in doubtful cases, you should refer to a specialist on fetal ultrasound. And it is definitely the case that diagnosis leads to an improved prognosis, especially in the cases where you may have a restrictive foramen or restrictive ductus arteriosus needing neonatal resuscitation. And the challenge is still the additional information required, but I'm sure once it is known, prenatal and postnatal, there is enough experience on this field. So I thank you for your attention and look forward now to the talk of my friend.